Hi, everybody, and welcome to a very special episode of the Serdentity podcast. I am so excited to be here with this beautiful young lady today who happens to be my daughter. My daughter, Kelly Sciarratta, and she is a goddess, and she does great work with people who are trying to get off the streets and get into recovery. And she has a lot of experience in trauma-informed care, and she also has experience as a dental patient with a lot of disease. So I wanted to talk with her today about both of those things. Hi, baby.
Hi, Mommy.
How are you?
I'm good.
How's it going?
It's going good. It's a little warm today, but I'm always ready to talk about trauma-informed care.
Mm-hmm. So for me, so Serdentity is about dental trauma.
Mm-hmm.
And patients become traumatized in the dental chair by providers like me, even though we don't mean it. And so Serdentity is, I'm trying to reach out to my fellow professionals to give them more information so that they can have a better experience.
Mm-hmm.
And a lot of times patients that present as rude or hostile, belligerent, that people complain about in Facebook groups, most of the time these people have been traumatized and their presenting behavior is defensive.
Yes.
So tell me in general, what do you feel about trauma-informed care? What do you think it is?
So to me, the essence of trauma-informed care is, where it has to start, regardless of what discipline you're working in, the idea of harm reductive care. Mm-hmm. So when people hear harm reductive or harm reduction, the first thing that comes to mind is syringes and people injecting in alleyways, and it is that, and that shouldn't be hidden. But the spirit of harm reduction is meeting the patient or consumer, whatever language is in the discipline that you work in, meeting them where they're at upon arrival to the office setting.
Harm reduction is very applicable in the dental setting.
Yes.
Because we harm people all the time, even though we don't mean to.
And a lot of that is this, it's like this iatrogenic harm, right?
Yes.
So it's
oh
this
my God.
idea that it's unintended, it's done well-intentioned even.
Yes.
And something that I found working across many disciplines through psychiatry, psychology, addiction, working with DV survivors, victims of trafficking, sex workers, anywhere that there is someone seeking change and to sustained change, whether it's in addiction recovery, whether it's with oral health like mine. The idea is that we deserve to be met with what we're bringing to the table without the expectation that we're capable of bringing anything else in that moment. And I think that the idea that it needs, I feel like things get very tunneled across disciplines of medicine.
Yeah.
And, dentistry can be seen as almost non-medicine.
Oh, absolutely. Right.
And I don't mean to say that too.
No, but it's true though. It's true.
But it's almost seen as this paraprofessional medicine.
Yes, oh my gosh.
And I think that is where sometimes, and you see it in many of those that sort of get adopted, some of them get adopted from Eastern philosophy, like acupuncture. That's still a medical discipline. It's just viewed as and so that, I think, creates so much room for this unintended harm, because it's not being viewed as stringently, or the oversight and guidance isn't as focused on reducing harm as something like orthopedics, right, or a primary care office.
When I was in dental hygiene school, if you killed the patient, that was fine as long as you removed all the tartar. So it was about teeth and gums. And in dental school, they talk about teeth and gums, and they talk about, the bite, how the teeth come together, but they don't talk about how are you chewing? How is the whole rest? This is your craniofacial craniofacial respiratory complex. Okay, and it's all working together, but us dental people have been taught over the millennia it's the teeth.
Yeah. Make
them look pretty, make them work better without paying any attention to the system that they're in. Does that sound familiar?
Well, isn't on its face that's psychiatry in a way. dress up the outer, make it look pretty, make it presentable, make it accepted societally, and the job is finished.
Wow.
And those are fighting words. But, I think that if we're not bringing a spirit of, like, holistic and total wellness to whatever discipline we're in, all of it is fluff.
Oh my God. Well, holistic and wellness, those are marketing terms. And,
Right.
These dentists that, they market themselves as holistic, and really, they're still treating the mouth as separate from the body.
Right.
And, they're like, oh, let's get rid of those amalgams.
Mm-hmm.
Well, fine, but how is this person breathing?
Well, and I think another thing, too, is that let's say that I show up in your dental chair. I'm not your daughter. I'm fresh off of 5 years of IV heroin abuse and incredibly unhealthy living. But I think that if I wasn't your daughter and you didn't know what you knew about me, on the face you would just see a fucked up mouth.
Yes,
you would
exactly.
just see a really bad mouth. You wouldn't know that heroin makes you crave sugar.
Yep.
You wouldn't know that opioids make you crave sugar above anything else. You might not know that opioids cause vomiting.
Mm-hmm.
You might not know that it causes open mouth snore breathing when
Mm-hmm.
you're intoxicated or when you sort of nod out. So I think it's like, if we're looking just at the addiction piece in where it interacts with dentistry,
Mm-hmm.
there is not really, as far as I know, really a lot of cross-education on substance use disorder and the way it prevents. Like,
It's getting better.
it is.
I learned a lot of this through my own experience,
Mm-hmm.
and because I had interest in it because of my own recovery. But it is getting more recognition.
Right. But, even then, it's still like, and then you kind of, when you see it on its face, and it's like, this is a really bad mouth, there's disease, there's cavities, there's teeth falling out, this and the other thing. The assumption is that the person is at fault.
Exactly.
And I think that what that is it's still this very stigmatized view of whether it's addiction, any sort of recurrent disease.
Mm-hmm.
Because diabetics have bad mouths too.
Yeah.
And people on chemo have really brittle enamel.
Yep.
So
And
I
a
did
dry-
my research before I came.
You did. And a dry mouth. Yeah.
Mhm.
But so what happens is these people present in dental chairs,
Mhm.
and the dental provider's like, oh my God, this mouth.
Yeah.
And then the patient, right away, bam, you're going to have a downward spiral
Mhm.
because the patient feels that judgment from this person who's supposed to be caring for them,
Right.
health care provider,
Mhm.
and instead it ends up being a shaming, probably painful experience.
Yeah.
So the patient is acting out based on pain,
Right.
and then, they somehow get through the appointment, and that patient's like, I'm never coming back here.
Mhm.
And then the hygienist is bitching on some Facebook site about, oh my God, it's not the screen patient today, blah, blah, blah.
Yeah. And then, you start to get into doing dental procedures and the idea of pain control comes up. And then if someone has any scrap, like me, how long was I clean when I went to the hospital for my kidney stone? And I was
Right.
still getting grilled about, oh, you can't just come in for morphine. As I'm like urinating my pants, throwing up, screaming, crying. So the idea that if anybody has even a whiff, when things become chart lore, I think is something that in dentistry, it's a good term, right?
Chart lore, oh my God.
My NP Psych, Marty, I love you, girl. She was my NP Psych at Helio. Never heard the word chart lore.
That's amazing.
But that's exactly what it is. Because if something gets put in a chart a million years ago, that will get pulled into any note that even breezes by the subject.
I have a story about chart lore.
Mm-hmm. Oh, I have many.
Right. But in a dental, I had a patient, this was when we lived in Colorado. This was my first time seeing this patient. And pages and pages of how he's uncooperative, he's rude, he gags all over, blah, 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 blah. So the patient gets in my chair, and within minutes, I noticed that he's drunk.
Mm.
He had that sallow
Yeah.
complexion of a chronic late-term alcohol abuser.
Mm-hmm.
So I go over to doctor. I'm like, this guy's drunk, and he goes, oh, he's always drunk. I'm like, nowhere
Yeah.
in his chart was it noted that this man.
Presents under intoxication.
Right.
Yeah.
So, I did the best I could with him that day. I talked to him. So I'm cleaning his teeth, and we just started talking about drinking.
Yeah. It's that easy. That's the thing.
Right.
That's what makes me actually insane, is that I feel like when it's anything around substance use disorder or addiction or alcohol, whatever term du jour you want to use,
Right.
It's all the same thing. It's all the same, compulsive pattern behavior and inability to sustain change. That's all it is, regardless of the substance. But what's crazy is that it's literally that easy. Mm-hmm. It's literally that easy to just be like, you look like shit, and you look like you feel like it.
Yeah.
What can I do to make it better in this moment right now?
Yeah.
That's all it takes.
Yeah.
And I've never had that go wrong for me. Well,
it can go wrong occasionally.
It can go wrong, but I've never had it go catastrophically wrong,
right.
or wrong in a way that prevented me of being of service and support to that individual.
Yes. Well, when I first started the conversation with this patient, he was defensive. Mm-hmm. But as I continued working on him with a gentle touch, I was able to get past that, and he was able to admit, wow, my life is really stressful. Mm-hmm. I'm running around like a chicken with my head cut off, blah, blah, blah. And by the end of the appointment, we had established a nice rapport. He came back 2 weeks later sober.
See? I have so many incredible stories from across my work and across my recovery of having that initial contact and having it be paid back in full and having it just be such a rewarding, and I don't know, maybe I'm naive, but I always thought that that's why people got into the business of helping.
Right?
Whether you're a doctor, a CNA, a dental hygienist, a freaking receptionist, you're in the helping profession. And I don't know, I guess that was like a very naive thing.
Right,
I was just like, oh, they want to help people, but I'm so glad that you emphasize with a gentle touch, because, when I worked at the hospital, I worked in a unit that was primarily IV drug users. And in the hospital, especially if you're dealing with something like endocarditis or MRSA or, some of those really bad soft and skin tissue, all of those yucky IV antibiotic types, nobody ever really talks about how triggering it can be for a person in recovery to get a indwelling IV placed. So something that I made a mission of mine was, if someone was getting, let's say, a PICC line, I would be in the room when the PICC line is getting inserted. I would have a discussion with the IV team beforehand. I say, hey, this person has a history of risky IV drug use. The feeling of something in their vein could possibly be triggering. Can we handle this a bit more delicately? And as I worked more and more with the IV team, with the PICC team, the same approach for any PICC line started to fall away. And the idea that, we can tailor our approach to this specific audience, and it's like, wow, what a novel thought.
Right.
But I think that, medicine, regardless of discipline, is incredibly paternalistic. And there's this thing called the Spectrum of Attitudes by William Lufquist, who is the godfather of prevention. He started working with middle school and adolescents, young adults, around substance use disorder prevention in the 80s, and he created this thing called the Spectrum of Attitudes, and there are 3. The first one is object. When you treat someone as an object, meaning that's how medicine treats you. You are objectified.
Right, yeah.
There is no free will. There is no concept of choice. There is no gentle touch. It's just harm. Basically, fiduciary, iatrogenic, any possible kind of harm that you can put on a consumer. That's what you're doing. Then you move to recipient, which is, I'm giving you the illusion of choice. Being a recipient is me being in drug court and them saying, so we decided for you that the best plan, don't worry, it's going to work, is blank. So this is your tailored court systems.
Right.
This is some sponsors. This is, some recovery modalities. And then you move to resource. So treating someone as a resource is saying, the answers are in the room. I know that they are here. They do not lie with me.
Wow. They do not lie with me. Well, so a problem that you have in healthcare providers in general is this codependent fixer.
Yeah.
So, hello.
I wasn't gonna say anything.
No, but it's that's exactly, trying to fill an internal need to help, but being so constricted in this like tunnel vision and being very unaccepting of anything else.
Right. I think it's also like those of us who are on the giving side of any healthcare or any sort of support are taught to not trust the sense of self of the consumer. So this idea that the answers are in the room and they're not with me, that's just like, well, what do you mean? Because I was taught the answers.
Yeah, that's right. I know, you don't.
And so that's where we get into that unintended harm, because even at my most desired, helpful, compassionate state, if I am overriding the autonomy of the consumer, I am causing harm.
Oh my God. And in the dental profession, this presents as, well, this patient, it's supervised neglect. I need to dismiss this patient because they're going to sue me. And, and that goes into a whole rabbit hole of, well, why do people sue providers? Because they feel like they're not being listened to.
Right. People
don't just sue providers for no reason.
It reminds me of the story where it got turned into a joke, right? That poor elderly woman that got the McDonald's coffee spilled on her, and it was like, this big poster child for
frivolous
lawsuits. And then you come to find out this shit was like 500 degrees,
right.
And this woman got like
third degree
burns.
Yes, she had all thighs and everything were blistered.
So it just things like that happen, and I'm just like, is this a McDonald's coffee situation? Where it's just like everyone is painting this patient as provocative or non-redirectable, whatever lingo is being used.
Oh my God, non-redirectable.
Then it's like, well, is the coffee 500 degrees?
Right. And in the dental office, it always comes down to breath. Since the vast majority of people are mouth breathers, they come into the dental setting, and where are we working? In their mouth. And so the patient, and they might not even be aware of this. It's their primitive brain protecting their airway. And just like, so the brain has an impulse, and then the mind wants to attach a meaning to it.
Right.
So,
and sometimes there's not one.
Right. Sometimes there's not, but a lot of times, the patient will, attach a meaning to it, and then that becomes future trauma. Because they become afraid of that attached meaning happening again. And guess what? It does.
Yeah.
What I say to most fearful dental patients is, we've trained you to expect a bad experience, and we've never let you down.
Yeah.
So it's really terrible. And after years of listening to these people and how they speak about their experiences, I really came to believe that, there's a better way.
Yeah.
And when I approach a patient, especially these, what was that word you just used? Non-distractible?
Non-redirectable.
Oh my God, that is the greatest word ever. I'm going to use that all the time.
That's a psych hospital term.
I
am myself am quite non-redirectable at times.
Yes, I know. Non-redirectable, like, this patient comes in and refuses x-rays. They can say it's because they don't want to pay for them. They can say it's, I'm concerned about radiation, which they might be. But the real reason is they have bony protrusions in the bottom of their mouth, and they can't breathe when the x-ray sensor is in their mouth.
Or then you get non-compliant with care.
So then not compliant. Oh, we're going to have to dismiss, oh my God, this person hasn't had x-rays in 3 years. Like, well.
Yeah.
Yeah.
Well, and I was so lucky that, when I first got clean and you guys took me to the dentist, it was a very, very awful first 2 appointments.
Oh my God.
And I definitely felt the judgment from the dental team, but can I say their name?
No.
So
Dr. So-and-so.
So this dental office treated me very, very well after a rocky start, and I am eternally grateful for the fact that my dental hygienist, who would clean me up every time before I would sit with the dentist to get whatever 50th filling I needed that day, I literally had like 25 fillings.
Yeah, you had decay in every single tooth.
Yeah.
And I remember crying. I cried.
Yeah.
When I looked at your x-rays. Because you are a 90s kid who grew up with no cavities. You had braces, the whole 90s, wisdom teeth removed, the whole 90s thing.
But you know what happened to the 90s dental kids? They all turned into the 2010 opioid kids.
Opioid kids and sugar addicts and energy drink addicts. Mm-hmm. And so now they grew up with no cavities, and somehow we thought that we could save you. Yeah. Like provide our kids with a lifetime of great dental health by getting them to adulthood with no cavities. Mm-hmm. But that's not true.
Well, and that's where, like, not to get all like clinical psychology, but like the trans theoretical model or the stages of change, that's why it doesn't end. Because, once you get someone from pre-contemplation to action, then guess what? There's maintenance forever.
Yeah.
And sometimes relapse occurs. And you can always jump back in. You don't always have to go back to the beginning. It's any sort of chronic thing, whether it's poor dental health, IV drug addiction, COPD, anytime that there is the opportunity for a change behavior, this model hasn't really failed.
Right.
And it hasn't been failing since the 70s. So the idea is that education and support, harm reductive education, compassionate, non-judgmental support.
Oh my God.
And that's what maintenance is. And I feel like what happens is that maintenance is always expected on the participant, but maintenance is just as much our job as helpers.
It absolutely is.
And that's, I think, where things like fall off.
Yes.
And of course, we live in a very individualistic, capital driven. So it is hard to provide maintenance in compliance with, whatever program that you're in. And there are productivity rates that need to be acknowledged. And there are, we do have to be results based to a certain point. But man, I can't even emphasize enough how much a 6-week check-in phone call that lasted 10 seconds. Mm-hmm. Sometimes it's just, hey, I think that you got out of rehab recently. How are you doing? Mm-hmm. I got into a transitional rooming house, but I could use some clothes. You know what? I'm going to call my friend at blank grassroots agency, see if they can drop some clothes off to that shelter. Wow. All right, beautiful. And then you know what? Nearly every time I've seen that person at a fucking meeting in the next 6 months doing great. So, like, just that very limited continued contact, whether it's it can be the receptionist at a dental office. Hey, you got some crazy cavities filled. How's your mouth feeling? Mm-hmm. Oh, you know what? I'm actually out of that special toothpaste. Perfect. I'm so glad I caught you today. This is where you can buy it. Mm-hmm. 30 seconds. You can document it. You might even be able to bill it for Medicaid. If you're so worried about that, you can bill so much stuff that I think it's just like thinking outside of the box of that.
So, and the dental, because we're so focused on the mouth, we focus on the teeth and plaque and removing plaque, and you need to floss more. And the thing is, people don't floss their teeth. You know who flosses their teeth? Dental hygienists.
Right.
I have never seen a super healthy mouth in a general dental practice. Hardly ever. You see them in periodontal practices where these people come in every 3 months and they've spent thousands of dollars. Okay, in the average general dental practice,
like you're just run-of-the-mill neighborhood.
Yeah, run-of-the-mill, and a run-of-the-mill suburban practice, the average dental health is much better than the run-of-the-mill urban practice. Mm-hmm. And, when you start to go down the socioeconomic scale, oral hygiene gets worse. And don't get me started on nursing homes.
Yeah. Because well, it's like anytime you take protective factors away from someone and you're just adding to those determinants of health or taking away from them, why do I care about my teeth when I'm homeless?
Exactly.
Why do I care about my teeth when my friends are dying around me? Why do I care about my teeth when I'm not even eating anyway? So what's the point in brushing? I haven't eaten in 3 days.
Right. And there's so much more to oral health. Mm-hmm. Okay, this is a biome. This is an ecosystem. And there's a lot that we can do to make the ecosystem less friendly to the destructive bacteria. Mm-hmm. It's not all bad. Then Listerine is like napalm. Okay, you're going there.
Well, it's because I would assume it's like taking antibiotics and then getting a gross, like a yeast infection. Because you wipe out everything, and then there's nothing good left.
Right. So,
I can't believe I just thought, oops. Ignore that
no,
part.
No, that's all right. Listen, it's the same, too.
Yeah.
Anyhow, we're always talking about floss, plaque. There's so much more.
Yeah.
And, we need, in the dental profession, a complete paradigm shift. Mm-hmm. Stop thinking about the teeth. Stop talking about the teeth, how to make them pretty. And let's start talking about the orofacial respiratory complex and the orofacial digestive tract. And, when we start to do that, we're naturally going to not traumatize people as much because you're not coming at them with this drill and fill mentality. So that's what I'm trying to get across to my fellow professionals.
Well, I remember when I was much younger, there was a time where you got in trouble at some podunk office for offering aromatherapy during a normal cleaning, and that was the biggest deal. And I was just even in my however old brain, I was like, our house smells like that all the time. What's the big deal?
Right. That's
God
right.
God forbid you add a scrap of comfort.
Right, comfort.
Well, and I think maybe that is the whole point, is that there is some sort of inherent belief that people don't deserve comfort, that people deserve to be punished.
That the medical religious healthcare model is it's still there. Mm-hmm. Well, in scriptures, this blind guy, the apostles are like, Jesus, who sinned that this guy's blind?
Right.
And Jesus is like, you're kidding me, right? He's not blind because someone sinned, you idiots.
Yeah.
But
maybe he was born like that.
He was born like that, but there's the assumption, that there's some guilt on part of the
moral model.
Yeah, the medical religious. So, what was I saying? Oh, I had some brilliant thought too.
Not blind. Before that.
Mm-hmm.
Before medical religious.
Yeah. Medical religious. Oh, well, it'll come to me.
Wow, we're both fried.
Yeah. Oh well. But aromatherapy and trying. So the professional. So the man that figured out that you need to wash your hands to prevent. Had some weird name, Ignac, like Igor or something. But he was maligned by his fellow professionals, and he ended up in an institution. And he's the guy that figured out that if these doctors going from an autopsy to a birth and not washing their hands, they called it childbed fever. It was a freaking infection.
Yeah, they probably went septic. Immediately.
So this doctor's like, hello, everybody just wash your hands. But he wasn't nice about it.
Right.
He was very confrontational. And so he was maligned by his fellow professionals.
Yeah.
And there's these two orthodontists in Great Britain who right now are fighting all kinds of legal action from the Orthodontic Association of Great Britain because they dared to say that, teeth aren't crooked because of genetics. Teeth are crooked because there's not enough room in the bone. The bone didn't get a chance to grow enough because these kids are mouth breathing and it stunts their growth. And so their treatment is based in that model.
And correcting the breath?
Yeah, correcting the breath, getting the tongue up and forward, which is what I'm doing in orofacial myofunctional therapy.
Right.
So their whole thing it's almost the complete opposite of traditional orthodontics, which says take out teeth and smush the rest together.
Yeah.
Which is what I had, which is why I have sleep apnea, because my...
Well, do you remember all of the stuff they had to do for my mouth?
Yeah.
Like those horrible spacers that I had to have.
Right.
My little overlapped bunny teeth in the front, which I thought were cute.
They were kind of cute.
Could always go back. Just like...
Oh, they will.
But, I mean, I think that's always what it is that in these very regimented, historical, prestigious, paternalistic disciplines, the idea that something that deviates from tradition is always harmful. And
yes,
bad.
and it's wrong because if it's
the
different,
world is flat. No, it's not. What? No,
right.
that's the whole thing.
You're out of the church.
Yeah.
Like, that's a punishment. Anyway, but yes, so so the dental profession needs to start thinking out of the box. We need to start opening our minds to and getting out of our these silos, and start thinking about, what is actual holistic treatment, what is actual wellness, and that is my message. That's my message to my fellow professionals. And the thing is, when we act in that model, it's better for everybody. It's better for the patient. It's better for me. When I had those, and you know what? I hardly ever had those kind of reactions that I read about in these Facebook posts.
Yeah, so then what are you doing to cause this? I think that what it is that it's like a very blame shifting or dodging. Because it's like, I couldn't possibly have done something to cause this sort of, you know, and I would see it all the time with, people getting labeled as med seeking. Meanwhile, they have a half dead foot rotting off, but because they came in under the influence of heroin, they couldn't possibly be in pain. And so, just stuff like that. And I think that what we both are sort of yearning for is camaraderie among disciplines, because I am your professional collaborator.
Yes.
There could and probably should have been many opportunities for our service lines to have intersected.
Right.
And I think that, there is the sense of being siloed. There are very regimented disciplines in, broad medicine and then even in the individual specialty medicines. But, I feel like the sense of, I guess, competition amongst services.
Yes.
I really wish that could become more friendly as opposed to results-based and numbers-driven.
Yes.
If that makes sense.
Evidence-based. And here's the thing about evidence. Okay, patients don't care about empirical evidence.
Yeah.
They don't care about studies.
I didn't until it was my job.
Right. Patients care about anecdotal evidence, about the experience of their wife, their husband, their cousin, their freaking next door neighbor, the guy down the street. I had a man come in right before we left Colorado Springs. His mouth was a disaster. He had so much tartar, but he wouldn't allow me to use the ultrasonic cleaner, scaler, because listen, they did that to my buddy and he lost his teeth.
Yeah. And you know what?
No amount of convincing.
That becomes Bible. That becomes.
There was no amount of convincing. Well, look right here where it says in the pub research blah blah blah. He doesn't care.
Yeah, and I've never really met a patient that cares what best practice is.
Right.
Because it's more about what is this going to do to help me, and how is this going to improve my life? Because if it's not even going to do one of those things, I'm out of here.
Yeah.
Especially when you're dealing with the psychiatric or substance use disorder man, listen.
Yeah.
I don't care. I got shit to do. I'm already half dope sick in this chair. I did this to get my mom off my back. Literally, I'm speaking verbatim from my experience. I'm doing this shit to get out of here.
Yeah.
So do whatever you need to do, and trust me when I say that I will never be back. And that gets translated as non-compliant, as rude. But in my head, as I'm sitting in this chair, already hating myself for what I have let happen to my life, my body, my mouth, I can feel it on you. And trust me when I tell you that if you want to do it, I'll do it better because I've been doing it longer. And then those two feelings become associated, and you can no longer untangle my self-loathing from the presumed disgust that I fed from, or that I got from you.
Right.
And then I'm very big on associations. Associations are everything.
Yeah.
And if I can create a positive association, even in a place like a sterile clinical hospital, if I can create an association of safety and vulnerability, it will succeed.
Yeah.
Even if it's just hanging up some chintzy art on the wall and putting some clutter around, because you know what that feels more like? A home. And then if you have an association with a home or with some comfortable environment from your past, whether it's, I've had people tell me that it reminded me of their kindergarten classroom, which is the last time that they felt safe.
Yeah.
If you can forge those neural connections
Yes.
around a safe, good association, you will have success. It's just about not rushing it, I guess. And that's what makes me sad about people, professionals in your position, is that you guys don't have the luxury to not rush.
Right. This is
so then it's like, I need your whole life story right now. Scrape. All right, fuck off. And
Right.
like, you know, it's like, I need your life story, but while you're telling it to me, I'm doing this awful thing in your mouth. So now I'm creating these associations with this feeling and these, with this physical feeling and this emotional psychiatric feeling, which was already bad to begin with.
Right.
And now I've made it worse. Here's your bill.
Right. And you better pay it. And yeah, and we don't take your insurance.
Yeah, by the way, at
Because
the end of
they don't
everything,
reimburse.
also, yeah.
Yeah, right? But, I was going to say something again. Damn it.
Maybe we should just have another podcast.
Right, associations. Yeah, well, we probably will.
We could just gab all day.
Right, I literally could talk to you all day. You know, and it's been at like a half an hour or so, and that's about anybody's attention span.
Yeah.
So, you know what? I love you because you're my kid, but I really admire you because you're wicked smart.
Oh.
And, you know, you are really, you're really doing something. And I love to see my passion reflected in you. And,
well, I don't think I would have been able to make the inroads in transforming trauma-informed care in the environments that I'm in if I didn't have a model, unbeknownst to you most times.
Right. So, yes, we'll probably do this again.
Yeah, that would be awesome. I have so much more.
So much more to say.
So much more to say, as per usual. We're
Right.
born yappers.
Right. All right, well, thanks everybody for tuning in.
Bye.
Bye-bye.